Hello, I'm Sarah Day, Policy and Research Manager at HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. This episode is the second in our series of weekly conversations with Sanjay Agrawal, an HFMA trustee and a consultant in respiratory medicine and intensive care at University Hospitals of Leicester NHS Trust. As admitted cases of Covid-19 begin to increase in his hospital, Sanjay talks about running virtual clinics and supporting patients who need care but do not have Covid-19. He also begins to think about what this will mean for how the NHS will be run in the future. Hi Sanjay, thanks for joining us again. So how have things changed for you since we spoke last week?
Yeah, thanks very much. So I thought it would be useful just to give you an idea of patient load, if you like, in our intensive care units and on the wards. So we get a daily SITREP report, which is really helpful from the trust that goes out to all staff. And I think on yesterday's SITREP report, there are about 120 people in our trust with who are COVID positive for sure. That, of course, doesn't tell you the story about how many people are suspected of having COVID, but we don't have the positive swab yet. In intensive care, we have three hospitals in our trust, and we have three different intensive care units, and across each site we have different number of COVID patients. In my particular intensive care unit, we have about 10 COVID positive, and comparing it, say, to this time last week, we've doubled the number. And of course, the $1 million question is, how quickly that doubling will keep on occurring. Across the rest of the hospital, I would estimate that, again, we've probably had a doubling of COVID positive patients on the wards in addition. And that's just the COVID ones that we know about. What's quite interesting is that we've had patients who developed positive swabs on, say, surgical wards, as well as coming in through our emergency admission routes or our clinical decision unit. So, as expected, we do have an increase in numbers, and I'm sure this is going on across the country. So the things that we've been doing over this past week are, again, quite a lot. Somebody said to me the other day that every day seems like a year at the moment, and that's true. And I think my wife was telling me that she read on Twitter somewhere that in fact it doesn't feel like a month; it feels like an era. The month of March was an era; it just feels so long, and I think that's true. But I thought it'd be useful for people to understand what we're doing in my trust and what I've been involved with. So the first thing I would say is that we're freeing up space for emergency care. We're trying to reduce the amount of elective work. So with my respiratory medicine hat on, that means converting a lot of our clinics to virtual clinics. I personally have been trying to clear my decks for the next 2 months. So I've been essentially doing virtual clinics constantly for the last few days, calling up people who had a scheduled visit and essentially doing the consultation on the phone, but still generating a letter that goes to their GP and to the patient and to anybody that I might need to let know about that consultation. And that's worked really well. I have to say patients have been really accepting of virtual clinics. They totally get it. Some have been able to talk about their concerns and worries about COVID and asking whether they're a vulnerable patient or not. So that's worked really well. One reflection I had is that pre-COVID, there were different tariffs between telephone clinics and face-to-face clinics. And I would say, certainly for me, I put in as much time doing a telephone clinic as I do a face-to-face clinic. So it'll be interesting going forward if we do telephone clinics as a new way of life in the future, which I think is sensible. I wonder what tariffs will be for those clinics, because I think that's going to be important. The other clinic that we've been trying to do, which is much more time sensitive, is a cancer clinic. So we have lots of people. We have about 2,000 patients referred to our hospital for potential cancer, lung cancer from GPs, and we're obviously having to manage those referrals. It's true to say that referral numbers have come down, but they're still significant, and many people will have potential lung cancer or lymphomas or other types of malignancy that we need to investigate. And it's still a time-sensitive pathway. So we've very much been trying to make sure that it's our triage clinics and face-to-face clinics and our lung cancer MDT that we've not been disadvantaging those people who would benefit from the normal pathway in terms of timely tests, making decisions and getting them to a treatment-based clinician such as an oncologist or surgeon. Interestingly, new guidance nationally has been delivered about which oncology patients should crack on with treatment, and we're using that national guidance in our MDTs. So that's my respiratory side in terms of freeing up space for emergency care. In terms of intensive care unit, pretty much all elective surgery has come to a halt. We're doing emergency operations only, and in my intensive care unit we predominantly see patients with who are having cardiac surgery, and so now we're only doing urgent coronary artery bypass grafts and the like, and again that has freed up space ready for the expected influx and the peak in our area, which is projected to be in the next 2 to 3 weeks. Staffing has been another big area where we've been involved with in the past week. Things have evolved a huge amount. We're in a good place, I think, in terms of new rotas. So, for instance, in my intensive care work, I have something called a surge rota. And so now we have 2 consultants on at a minimum day and night, as well as additional consultants. We've developed new teams. So if a patient needs intubating on the ward, we have an intubation team. We have people who are identified as 3rd or 4th on should we need them. Our trainees have been moved from anaesthetic rotas now that they're not doing elective surgery to an ITU rota. So I think that's worked really well. Similarly, in respiratory medicine, new rotas have been produced for covering ward work. And interestingly, there were some patients some staff who were thought to be high risk because they're older staff members, greater than 60 years old, or have comorbidities themselves. And we tried to protect them by them doing less patient-facing work and doing more of the telephone clinics. So that's worked really well. And I have to say, staff have been really flexible with the new rotas, and it's been really good to see. Now, there's also been the question of what do you do with staff members who are in specialities where their work has been taken down. So, for instance, elective surgery, or you could argue some radiologists who aren't doing as many tests as they would normally, be it CT scans or biopsies or ultrasound scans. And I know nationally this is a big question about how do you redeploy those staff. And again, we've had some discussion in our trust about that, but I think there's still a way to go. And I think we still need clarity because I would say it's now, it doesn't really matter what speciality you do or subspeciality you do. We're all doctors. And we all went to medical school, and people can apply their skills generically. And I think that's what we need to do. But we've still got a little bit of a way to go on deciding who goes where. One of the things I've been talking about, and I think maybe we can talk about at the end, is the impact on staffing going forward. Because if everybody's at a stretch now, when we get back to pre-COVID work, and there's going to be a huge backlog, somehow we're going to need to pace everybody because nobody will have had any leave, etc. And so how we reintroduce that postponed work and how we use staff to do that is going to be a really important consideration. And I think that's something that maybe finance and HR staff are going to be needing to think about, because I think the pressure on staffing is going to extend for probably at least a year or two, and it wouldn't surprise me if we see many retirements going forward. And we already had workforce shortages before pre-COVID, So I think they're going to be exacerbated, and it's something that we might need to work with universities and other sectors so that we can train people so that we can introduce them to the workforce sooner than later. The next area is PPE, so personal protective equipment. My trust as around the country, obviously staff still have major concerns about having the right PPE to do in the right situation, and I'd be telling an untruth if there weren't concerns still about the availability of PPE stuff, especially the FFP3 and the gowns for when you're working directly with patients, whether you're doing an aerosol generating procedure or not. There's going to be some more national guidance, I believe, this week on that. But I suspect some of that guidance is going to be based upon supply and demand more than anything. In terms of other equipment like ventilators, again, there's been a lot of news nationally about organisations like Dyson and Formula One producing ventilators for the NHS, and I'm sure that is the case. We've not had any of that yet, but hopefully it'll come if and when we need it. Testing is another big area that I think is changing. So as everybody will have heard, there's going to be more testing of NHS staff so that if they're self-isolating or think they've had it, they can get tested to see, firstly, if they actually have it now, and if they don't, they can come back to work, or if they've had it in the past, which means that they won't have to self-isolate, because some of those people might have been asymptomatic with their infection. And I think we can't get that test to see whether you've had it or not quickly enough on the front line. I think it'll make a tremendous difference to our staffing level, which I have to say we're about at least 20 to 30% down on our medical staff at the moment, with people self-isolating or who've had symptoms. Next thing I just wanted to touch upon that I think is really important to mention is the caring and the attention to well-being that I'm seeing. So, in my particular trust, staff can now have at least one free meal on shift at work, and they go to the canteen and they're allowed to, pick up their lunch for free. There's free car parking. I think all of these things are really helpful. We've had people who have, say, printing businesses, 3D printing businesses, who've produced visors with the 3D printers for our staff on ITU, and that's been fantastic. We've had local business people and others delivering fruit and other food to our staff, which again is really, really helpful and supportive. The NHS appreciation and clap the other night was, again, I think touched a lot of our staff. So really helpful. We've had lots of really good communication within our trust about what the situation is and where to get help and, what plans are. So I think good communication's been key, and I think we're really getting there. So really impressed by the amount of caring, kindness and generosity that's going. But I think the funniest story for me was when I was doing a virtual clinic yesterday, and I was chatting to one patient and I was talking to him about self-isolation, and he said, "So do you think I should keep away from my wife?" I thought I better not comment on that when he asked me that question. Okay, finally, I think the other thing I thought I'd talk about today was planning for the future. So, this has been a major disruptive influence on the NHS. We've moved from a system where we accommodate emergency and elective care to one where we pretty much focus on emergency care. And one of the things I've learned, I think, in terms of doing things differently is these virtual clinics that we're doing. I think there's obviously a big role for those going forward, and we hopefully can do that. And we might need help with the CCGs and trust in terms of how do we finance that and make sure that it's paying for the work that's going into that, because I think that'd be really useful going forward. We need to think about focusing on what's important and what we can do. That's what we're doing in our virtual clinics. We're not doing as many tests, as many CT scans, X-rays, other scans, blood tests. And I think going forward, that's a really important lesson that we need to carry on with and make sure we don't overdiagnose, we don't over-investigate patients, and we treat people when they have symptoms and when the treatment's going to make a difference. So that's another big lesson. The other lesson is IT. Our IT department have done a brilliant job in allowing people access from home, so they can do hot clinics from home when they're self-isolating, and having a much better IT infrastructure, getting more results onto an electronic patient record is another big priority that I think we should sort of carry on with after all of this is over, because it's made a tremendous difference having access and working in this way. Not to mention the impact on not bringing patients to hospitals and staff not having to travel with respect to car emissions and parking and climate change and all of that. So it's a win-win all around, I think. And then finally, I would say that, we have a system that is a kind of a just-in-time system. Everything that we do, whether it's globalisation, capacity in the NHS, free beds, occupancy, it's just in time. We have a just-in-time model. But COVID has taught us that actually we need to prepare as well for just in case something really bad happens. And I think that'll be another really good lesson to take forward.
Thank you so much for your time today, Sanjay. That was a really comprehensive update of what's happening for you at the moment. We look forward to speaking to you again next week. Thank you. Next week, Sanjay has agreed to answer some of the questions that you might have about Covid-19 and its impact on the NHS. If there is something that you would like Sanjay to talk about, please email your questions to policy@hfma.org.uk and we will put some to him during the podcast. To support our members and colleagues, all Covid-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. It is important that we continue to support each other and keep our network strong. We will do all that we can at the HFMA to enable this. If you have any suggestions of other support that we can provide, please email us at policy@hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.